Welcome. So Dr. Safdar Ansari is a neurologist at the University of Utah. He is also the associate professor of the Department of Neurology at the University of Utah and the medical director of the telehealth department. So Dr. Ansari and I got the opportunity to be part of a couple of projects together when I worked for the Alliance. And he was just a very brilliant, or is, he's still here with us. He is a brilliant mind, and I really enjoyed all of his participation in the work groups, and I really appreciate you, Dr. Ansari, and for your time here today.
Thank you both, and please call me Safdar. I've known you, Hedi, for a long time. I've been looking forward to this opportunity to do this live stream, and Harry, it's a pleasure to finally put a face to the name.
Likewise. Well, I think, so what we're going to be going over today is, and again, people who have seen this workshop and know me, you know, you read Dr. Ansari's CV and you can always get intimidated. Sometimes you read off the CVs of physicians like, oh, he's so intimidating. But what do I always say, Hedi? Physicians are humans. And so we want to interact with that human part of physicians. And so in our book, we have various sections. And one of my favorite sections, and it's not because I wrote it, it's one of my favorite tools, is I think oftentimes we tend to talk a lot and we don't really listen a lot. So we tend to not ask a lot of questions. And again, this book, you know, and after you'll notice is that this can relate to any person, not just physicians. And so the part about the power of questions, I guess I will ask a question of you. So in your practice, we'll just get right into it. In your practice, how do you use questions when you're relating to your patients' families, and your peers? And if you have examples, that would be wonderful.
Excellent. Thank you, Harry. So yes, in short response, I do use questions. I use them extensively in pretty much all forms of communication, whether it is the doctor-patient relationship and communication, or it is physician to physician peer communication. I'll start with the first. In the kind of medicine that I practice, it's mostly acute care ICU medicine. I work in the neurocritical care unit. And so a lot of my communication is unfortunately not with the patients themselves, but with their primary supporters, family, and friends. And in the initial communication with all family for my patients, I'll always tend to start with questions. Very brief questions about roles, relationships, links to the patient, and then much more detailed questions about their level of understanding of what the patient is currently experiencing, what the expected prognosis is. And I find that in communicating with patients and patients' families, starting off with questions does three things. One, it sort of creates this dialogue and does not create a scenario where the doctor is the only one talking. It lets the family start the conversation. And two, it is really, really useful for me as the physician to understand what the family understands, because it helps me guide and tailor my communication to what their level of understanding and their perception is. And that helps me prevent situations where I might catch them off guard or be caught off guard myself. But the third and the most important thing why I use questions is because it really encourages family members to open up and be verbal and communicate and get over that hesitation and that intimidation that you spoke of. With communicating with both physician and non-physician peers at the workplace and the hospital, I think questions are valuable. Now, when communicating with nursing colleagues, with respiratory therapists, and all the other elements of an ICU team, starting off with a question helps me sort of frame the question in my mind, the concern in my mind. And there's also a way to frame those questions. Like there has to be a little bit of background information provided to the persons that I'm communicating with, and then leading up to the question that I'm actually trying to ask.
So
And
basically, not all questions are the same, is what you're saying.
I completely agree. Not all questions are the same. There are thoughtful questions and reasonable questions, and then some questions that are less so.
So can I ask you this, because this leads me right into another question is, do you feel there's a big difference between asking a question and questioning? Do you sense that?
I do, and it's a very good question. So I think that asking a question where you have a thoughtful question in mind, you've articulated your concern, and you sort of express it in an environment that is conducive to learning and sort of putting yourself in the learner's role comes across much better than just questioning. And I think that physicians and non-physicians alike in the hospital world or in any environment, we can tell when a question is being asked that is thoughtful versus a question that is being asked for the sake of a question being asked.
Right. And also it can be a little off-putting sometimes if you're being questioned, like your authority is being questioned or something like that. I know that for me, I can sometimes bristle if someone's questioning me, but also a thoughtful question, like you said, it puts you in a state of mind where you really have to be thoughtful.
I completely agree. And it's unfortunate sometimes. I think physicians should have the ability to face questions and be questioned. However, I do recognize that for most of communication happening amongst the medical team in a hospital, the questioning style will yield inferior results. And I think like asking a thoughtful question in a learning, educational sort of mindset will yield far more positive results.
So basically what you're saying is how that question is asked makes all the difference. How about when people are approaching you, do you find that you respond differently to how you're asked? And can you give any examples?
Absolutely, yes. I think that I would respond differently if somebody that approaches me with a very valid and thoughtful question posed in a learning format. So for example, and I'll sort of start off with an example to avoid. An example to avoid would be like if I'm in the middle of a busy ICU shift and it's an intensive care unit, so time is always short, always too many patients and always too many things going wrong and nothing's ever happening on time. And so if somebody approaches me in that scenario and simply states a data point and then says, can you come see the patient? Then that's probably not going to elicit as much favor and positivity from me. And it could be something as simple as any member of the team coming and telling me, oh, the patient's PCO2 on the blood gas was this, can you go see it? And it's abrupt, there's no context, there's no effort on the part of the communicator as to what they have done to address the question. And it's often not an engaging question. It's basically just kind of like a passing the buck kind of question. Now, in a similar environment, depending on who is asking the question, that person could do a little bit of appreciation of the context, appreciation of the other lab values and data in the background, and sort of ask that same question that elicits my interest in a way that is engaging. And so that same person in a similar scenario could say, hey, Dr. Ansari, like patient so-and-so's ABG returned with a PCO2 of this. I'm a little confused because the patient's ventilator mode is this, and I would have expected the PCO2 to be far lower. Could you help me understand why the PCO2 is at this value and what we need to do to bring it back to the optimum range? And
So,
here,
yeah.
Sorry, please go ahead.
I was going to say you used a phrase in there that I saw Hedi smile and wait her head too, because you said, can you help me understand what's going on here? Can you talk about why that is such a powerful change, regardless of how busy things are? Why is that phrase so powerful? Can you help me understand what's going on here?
I'll tell you why that phrase is so powerful for the general workforce in a hospital and why it's personally so powerful and effective with me. And I'll start with the former by saying that that specific phrase implies teamwork and collegiality. It implies that we're in this together, that the person who's bringing that question to me could be a resident physician, could be a physician colleague, could be a nursing colleague, a respiratory therapist colleague, could be any member of the medical team, but it implies that they are just as invested in that question and concern as I am, and they're asking for help, they're asking for teamwork, they're telling me, hey, I don't simply want you to just come and fix the problem. I want you to come and then also help me understand what the problem is so both of us can fix it together.
Wow.
That collegiality and collaboration is what all physicians are looking for, because nobody wants to be sort of like a one-person show.
Wow. Hedi, I'm not so sure I could have said that any better. Do you have any insights on what he just said? No, I'm serious. That's actually amazing insight.
Yeah, I think that was brilliant, and I agree. I think it's just very helpful. And one of the things that I think we often see is that, and I can speak to that as a nurse as well as just general a non-physician. I think sometimes there's a level of feeling like we don't want to bother a physician. We want to try and keep things as concise as possible, that we know physicians are really busy. They don't have much time. And I think in an effort to be concise and trying to just get our message out, we tend to talk at you. We tend to tell you, like, hey, the PCO2 is low, can you come and fix it? And maybe not quite as crass as that, but that's probably how it comes across to you, I'm assuming, based on your description there. Versus something that might seem a little lengthier to say, I just received the blood gas results and I'm not quite understanding what I'm seeing in the PCO2. I thought the ventilator settings would have taken care of this. Can you help me understand? Seems a little lengthier to say that, but yet that is so much more effective from what you're saying. And that's what we often teach in the workshop too. And I love your description as to why that's so powerful.
Can I make a comment about the length, Hedi? I completely recognize that giving more data is more time consuming, and that in itself can be more intimidating. And I'll make a suggestion, and I think that I know for sure this works with me, and I know that this will work with a lot of other physicians. Approaching us with questions, it would be very helpful to start with a quick headline saying, hey, I had a question regarding the PCO2 value in the last podcast. So the physician who receives that question immediately knows what box inside our brain to sort of tune into. And then give the background data and the question that you have. And then I'll even suggest one more step. I'll suggest to anybody who's approaching with a question to also have a short answer based on whatever they think is the best approach to that question. You can also end with saying, by the way, I think we should do this, but I'd like your involvement to help me understand if I'm doing this right. Mm-hmm. And that really will condense time, because a lot of times my experience has been that questions that reach me, the person asking the question is usually on the right track. They have an idea in mind. They know what they want to do. They just need the validation. Mm-hmm. And if they give me, or if they're giving us that question and their proposed solution or answer from the get-go, we're really saving a lot of time. And we're also giving a lot of validation to the person who's asking the questions, because as they walk away, they'll be like, wow, like I was on the right track. And that becomes a closed loop, and that becomes a positive feedback for the person who asked the question.
It's amazing that you articulate that so well. I'm just astounded, because it's what we teach, is that how do we engage people? And like you just said, it's a closed loop. Just by that interaction, however short that may be, the relationship is enriched. And what we've often said sometimes is you can have that same amount of time and that relationship can be strained. One of the things that happened to me, particularly in this texting world, this virtual world, one of the questions that I used to hate getting on my phone is, hey, are you in house? Oh, okay, so you just had a reaction to me just saying that.
Yes.
Great, great. Tell me what that reaction is all about. Why did that just get under your skin? I can see it.
And Harry, I think that you and I are going to have a very similar thought process here. But we are a cell phone based industry, and my cell phone is widely disseminated within my organization. And commonly I'll receive a starting text, "Hey, are you available?" Or even worse, "Are you around?" And that seems to be the catchphrase, at least in my institution. And I have no good answer to that, because a lot of my work, I'm in the hospital days and then nights. I'm still working, but I could be working from home. I could be working from a coffee shop. I could be working from my clinic. I could be traveling on the road and still be working. So the question is not meaningful. It does not give me an idea of what the person who's asking the question needs or is concerned about. It doesn't tell me which box inside my mind I need to turn on to be able to help the questioner. And a far more reasonable approach would be, and again, to Hedi's point, it would be a little bit more than the "Hey, are you around?" with the 4 words of that text. But it could be something as simple as, "Hey, I am struggling with a doctor-patient's family situation, and this is a patient who is a declared and deceased brain dead patient, consented for organ donation, but there is some conflict. Can I call you to run things by you?" And then there is no asking me where I am geographically, which quite frankly is an invasion of privacy. I don't need to tell you where I am to be able to help you. So a simple question framing the background and the question and the ask, rather than "Hey, are you available?" or "Hey, are you around?" In a world where, as physicians, we're kind of expected to be available or around 24/7, 365. So that, I feel, is an ineffective question.
So what's interesting to me, and I'll just make an observation, is so oftentimes we're asked in workshops, what did I do that set him off? And so that's a 4-word text. And you and I both had physical reactions. You could literally see Hedi's laughing. You could literally see like, ugh. And we're not even in a stressed environment. Imagine being in a stressed environment. You just walked in, your mind is foggy. Hey, are you around? And all these things just start going off automatically. The person who sends that text, and one of the reasons we like doing some of these, because they can hear it from me. I mean, I'm a physician, but now they're seeing the exact same thing from you, and we're talking about why that would do that. And what's even better is, what would be better? Hey, having a tough time with a central line. Would you be able to help? Well, that's different. And it's not that much longer of a text. Now I know what they need. I know what the issue is. Now I can start making time. I can't do anything with, "Hey, are you in the house?"
Absolutely.
That's great. Any questions from the chat?
One, I wanted to share a comment from the audience. Tiffany Miles was saying that asking the question fits into the 6 basic human needs that we talk about that physicians have as well, the significance and contribution. You know, demonstrating to a physician that they have significance and giving a physician the opportunity to contribute. And it also helps to increase trust between the healthcare professionals. The one observation I have from the 2 examples that you've given us, Safdar, is the Sbar model of communication, right? State the situation up front, give a little bit of a background, provide your assessment, and then make your request or recommendation. Now, in that vein, you are a neurologist. So let's say I, as the nurse or as the organ procurement organization coordinator, am seeing signs of activity when we have a brain death declaration already documented by a physician. The one thing that makes me nervous sometimes is the recommendation piece, right? Because the recommendation, what might make me nervous is the physician going to receive that, especially when they believe they just declared a patient dead, and now I'm concerned about, I'm seeing something that indicates to me that maybe this patient is not actually brain dead. So how would you propose I best say, how do I best present this to the physician?
I think that's a very, very interesting question, Hedi, and trust you to ask a really, really meaningful and complex question. I'll take a stab at it, and I'll use the Sbar method. I'll use the Sbar method by stating and labeling the nature of my ask first. And so I'm assuming that this is text or verbal communication, but I'd start with saying, Doctor, I have a concern regarding some motor movements, reflexive movements in a patient that is already brain dead. With that headline, any physician that is in any way remotely connected with brain death declarations and support and care after, you have gained their attention 100%, because that is something that we all take very seriously. I would proceed with giving a little bit of background by saying we observed no unusual or unexpected motor movements overnight, but starting this morning, when we stimulate the patient's legs, we see movements that appear to be more than just triple flexion, and they could be withdrawal. And this is happening consistently with motor stimulation. Here is then the problematic section, the assessment, because that is a fairly complex assessment to make. And often the coordinator and the nurse that bring this to my attention may not have that same level of confidence in their assessment. But one suggested assessment could be, I think that this is motor movements that are above and beyond triple flexion. I think this is withdrawal, and that is very worrying. And then I'll state my request, could you please come and give us a second opinion on these motor movements, because this really changes everything that we are doing right now. Mm-hmm. And so from the person on the receiving end, the minute the person who approached me asked their question, they stated what their concern was. So immediately I know that this is a high priority, high ticket question. Mm-hmm. And I will give them my immediate attention. I appreciate the background information that this is a new movement, this is a new observation, this wasn't present last night or yesterday. I recognize the gravity of it. I recognize the question being asked of me, is this a reflexive movement or is this a cortical movement? Mm-hmm. And I appreciate the questioner putting themselves into a learner role by with whatever their level of expertise and knowledge is, by saying, this is what I think, because then in my mind, I'm giving them that credit that this person is an active questioner, an active learner, not a passive questioner who's just like escalating the question to the attending physician without putting any thought into it. And then the request for my second opinion, my exam, my participation is very reasonable, very valid. Framed in that way, I would have no need to cross-question. I would immediately accompany the questioner to the bedside and examine the patient.
So let me ask you this, Dr. Safdar. Let's suppose this change of shift now, and I'm the nurse, I'm doing my assessment, and I've got 30 years of experience, and you get the call from me as the nurse. Dr. Ansari, I've evaluated this patient that you declared dead last night, and he's breathing. We need you to come talk to the family. How would that question go over?
I think that question is still very well worded. I think that it stated the problem very clearly, very effectively. I understand, okay, we are dealing with an issue of a brain dead patient triggering the ventilator. One of the possible outcomes could be that the patient is not necessarily brain dead, or alternatives, much more commonly, that this is an artifact. But in the way that this question was posed to me, even though I recognize that this person is extremely experienced, I didn't quite hear what their assessment was. And rather than requesting my input, my second opinion, hey, can you help us troubleshoot and figure out what's going on? It seemed to talk at me and say, you need to go talk to the family. because there are many, many steps that need to be done before I go talk to the family. So just talking at me and saying, this is what I'm seeing, this is what you need to do, is probably not the best way to approach that very delicate and very complex scenario of a brain dead patient overbreathing the ventilator.
So it's the same situation, but two very different approaches. And then you, on the other hand, get a different feel about the person asking that question.
Absolutely.
Great. That the one thing I was going to ask, I was going to flip this on the other end and put you in a situation where you have to talk with a colleague about a sensitive and charged subject. Do questions work the same way with a colleague that you have to question as you will with a family or with a patient? And do you have any examples at all?
I do have examples, and the answer is yes. Questions can be very effective when phrased and communicated effectively. I'll give you a little side note. In my teaching responsibilities within the School of Medicine here at the University of Utah, I'm involved with sort of the class that we conduct for med students in how to ask questions of their peers. So how to place a consult, how to call for a curbside question, how to phone a friend. And in my experience, there are certain, I'll start with a few examples of what not to do. I'll start with the typical example is just calling and stating a question without any background information or context. That can be sometimes frustrating, it can be ineffective. In another example, sometimes, and texts again are the worst offenders in these scenarios, but often phone calls as well, the caller will start off with a formal sort of presentation of the patient's story and history and physical exam. And me as the listener, like, I don't even know why that person is calling me. We all wear multiple hats. In my hospital, I am the physician champion for organ donation. I also work in the School of Medicine and teach in 2 different courses. And I do general neurology, stroke neurology, and critical care neurology. And sometimes I can guess what the question might be by nature of who's asking it. But if they don't frame it, if they don't state it up front, like, I'll just be listening or reading to the text and I'll be like, I don't know where this is going. And that becomes ineffective. So when I call my physician colleagues, and I'll give you an example of me as an ICU physician calling another ICU physician for what I would call a phone a friend consult. I'll start by texting, by being respectful of their time. And I'll text and I say, hi, so-and-so, I need a curbside or a phone a friend consult on a patient that I have with subarachnoid hemorrhage who is also in refractory shock. And I'm calling my MICU colleague. And they'll say, hey, yeah, I'm happy to help. I pick up the phone and I call them. And I say, hey, Dr. So-and-so, thank you for taking my call. This patient has subarachnoid hemorrhage. I am really struggling with managing their shock, which is so far refractory to 3 pressors. Can I run this by you and see if I'm thinking right or if there's any other suggestions that you have for me? I've stated my ask. The person on the listening side knows exactly which wavelengths to tune into. I'll give them the background. This patient is this old, came in with this degree of subarachnoid hemorrhage. We're at day 3, we've done these treatments. And then the shock started about 24 hours ago. We've done the following tests. We've delivered the following treatment. However, pressor requirements continue to go up. And I've ruled out an MI with an echo and troponins. I've ruled out other things by these tests. And then I'll summarize and I'll say, hey, like, do you have any thoughts? Is there anything that I'm missing? Can you tell me if I should do anything differently? And that's my request.
Great. Well, that is a great summary. You know, we talk about the power of questions, and I think you hit on, there's 7 of them. I think you hit on all 7 of them. That's great. Hedi, did you have anything? Those are the questions I had. I know we're coming up close to the end of our time, but.
Yeah, I think I just have one more question, Safdar. When you have a more challenging conversation that you have to have, let's say you need to address something that somebody else did, you know, whether it's a peer or you said you work with medical students. But also, I think I'd like to hear also how you navigate that with a fellow attending, or maybe even a superior. You know, if you have, well, I guess in your role at this point, maybe the chief medical officer, but you probably, I don't know if anything like that would come up. But if you had to navigate a more challenging conversation, do you tend to use questions in that situation too? And if so, you know, how does that benefit you?
I think that, well, I do use questions and challenging conversations and questions and conversations that regard either feedback or conflict or disagreements. Well, they tend to be challenging in every which way. I think starting off by establishing some level of commonality, depending on who I'm talking to. Let's say, for example, I'll take the easiest of the examples you gave me, a med student or a resident learning physician. By starting off by asking questions that help us arrive at a point of shared ownership of the patient. Hey, so-and-so, we just both finished night shift together, and I think that it's really important for us to diagnose this stroke and deliver the appropriate treatment. What do you think? Opening that way by asking a question, implying a shared ownership so that the resident physician or the med student appreciate that we're in it together. And asking a question, hey, what do you think about so far the data that we have as far as the MRI scan, the CT scan, the perfusion scan? Giving that med student and that resident physician an opportunity to share their knowledge, share their perception, share their insight. And once I've heard that, then it also gives me valuable insight into their level of learning and expertise. So then I can tailor my feedback and my constructive feedback to their level. So I can say to them, well, you know, you're absolutely right. The MRI did show a stroke. What I'm concerned with, however, is that the CTA showed this, and we may have missed that overnight. We did not recognize how important a large vessel occlusion was on that CT angiogram, and that is a very big deal. We may have missed that overnight. That was not brought to my attention. We didn't address it in the future. And then this is me moving on to sort of like the tail end of the sandwich. In the future, we need to pay a lot more attention to these studies as they come in so that we can escalate treatment, optimize treatment to every patient. And each one of these studies is important in its own right. So that would be a very generic example of delivering like timely critical feedback, starting with the question, establishing shared ownership with the patient so that whoever is on the receiving side does not feel like I am talking at them or I am talking to them. It's like we are talking together because we're both in it together. We're both a team taking care of that patient.
So there's something that you said that I absolutely love, and I do have a follow-up question on, if I may, the shared ownership. Because one thing we talk about a lot of the time is the importance of inviting physicians into the OPO team and putting ourselves onto the hospital team. But for organ procurement organization professionals, it can feel a little bit like, you know, you're not working for the hospital, you're external to the hospital. This entity that's coming in, how do you infuse yourself into a team, but also the importance of inviting physicians into the team. Where would you say is the shared ownership when you're talking about a potential brain dead patient or a brain dead patient with a potential donor? Where would you say is the shared ownership?
That's a very good question and a very complex question, as expected. I think that as an OPO representative, if I was on that side and if I were approaching a physician, I would try and come up with some opening statement, more likely a question that leads to the implied shared ownership. And it could be something as simple as, hey, Dr. So-and-so, thank you so much for all the time in declaring and declaration of this patient yesterday. It was very tragic, the nature, the circumstances of injury, but because the patient is young, potentially there are up to 6, 7 organs that are viable and able to be transplanted if things go well, and that will be great. Now, this is more of a statement, not a question. However, I've started off with sort of reinforcing with the physician colleague that we're in this together and sort of highlighting the silver lining for the tragedy. And often with physicians, especially physicians in my line or specialty where we're working in neurocritical care, which often ends up being a very high volume unit for brain death declarations, we tend to see more of the tragedy than the silver lining. And so reinforcing the silver lining with us creates a very positive shared experience, because then I as the physician will recognize that my effort, my time, my energy the day before is going to help and impact like up to 7 lives. And then following up whatever my coordinator colleague will ask of me or information or share information with me, like starting off in that positive shared ownership kind of way makes me much more willing to engage.
So may I ask a follow-up question to that then? Would you say there's more of the shared ownership? I love how you said, about the acknowledging, first of all, what the physician has been through. I think that's one thing that we try to highlight in the workshops. So don't forget the human being that you're dealing with and how hard that probably has been for that physician. The second part is you were talking about the silver lining and the lives that can be saved. Would you also say that the healing that donation can bring to the grieving family, is that also a silver lining from your perspective?
I would absolutely agree that that is a silver lining. And again, from my perspective in the ICU and the neuro ICU on the acute side of things, that silver lining is often very opaque to us because we are so far removed from the recipients, from the recipients' families. We often do not see a lot of the good, a lot of the value that organ donation brings to recipients because we're on the other side. We see more of the tragedy, the injury, the emotional toll that we take upon ourselves in helping families navigate the loss of a loved one and reaching a place of comfort to be able to consent for organ recovery.
Mm-hmm. Yeah, that's what we often talk about, is that the common factor that the OPO has with the physician is that family that's in pain and grief. That's who everybody can see, and how valuable it is to remind maybe the hospital team about the value that donation actually brings to the family. Because like you said, the last time you see the families when they're in pain, not the follow-up that the OPO was doing with that family and how much donation has meant to them, right? So I have a couple questions in the feed here. I'm curious of Dr. Ansari's thoughts about asking questions to the physicians in relation to following up on a variance or missed donation opportunity on a unit.
What I understood the question, Hedi, is how to approach a physician when the question relates to a missed donation opportunity on the unit, a missed referral.
Yeah.
Excellent. So again, that's a very, very tricky and a very challenging scenario to be in. I think that starting off with a question here would be extremely valuable. And it could be something as simple as, hey, Dr. So-and-so, could I just have a minute of your time to sort of review patient so-and-so that you were involved in the care of last week? And so that is a very simple, broad opening question. The minute the physician says, oh, yes, what about that? Then that sets the stage for a little bit of background. This patient came in with this injury and progressed in this way throughout their hospital course. My concern is that the referral to the OPO came in a not very timely fashion. It was delayed or it was missed. And I completely understand that ICU is a very busy environment. And we want to review this case to learn and to educate ourselves and how we, in partnership with you, the medical team, can minimize this in the future. Do you have any thoughts now that it's, you have a minute, it was last week, it's done and over. Do you have any thoughts from your side that we could do differently, from our side that we could do differently? The key element that I would suggest in this environment is to ask questions and acknowledge both sides, so that consistently throughout that conversation, we recognize that there are opportunities to improve on both the medical team and the OPO. And so at no point does the conversation come across like a pointing of a finger.
I think that's the key.
Yeah, I just love how you put that together, because you avoided the word but, which basically means both sides have equal impression. I don't know if you did that on purpose or not, but I've not heard you use the word but. And of course, when you use the word but, anything that comes before it is invalidated. Yeah. And the second thing is you continuously come back to getting to a shared understanding through the use of questions. I think that's just wonderful how you do that.
I think that, Harry, I would just reemphasize that when having any intimidating conversation or challenging conversation, I think the word but should absolutely be removed from the vocabulary. And at every point when we either make a statement or ask a question or ask for feedback, we should think objectively of all the parties concerned, and we should share both perspectives. In the OPO and the medical team world, it's fairly easy because those are the two big pieces of the puzzle coming together. So in every opportunity, it should be, we're doing this, could I ask you what your team is doing, or what should we have done and what could you have done? They all have to go together.
Wow, that's fantastic. Well, Hedi, I know we're coming up to the end of our time, but yeah. Let me just say before we get off, Dr. Ansari, Safdar, great meeting you virtually. Loved your comments. I learned something today. I hope our audience learned something today. But Hedi, you want to wrap up?
Safdar, thank you so much for your time. I think you just gave a lot of gems to us at this point.
Loved it.
And also to all of you who joined us and dialed in and posed some great questions. I so appreciate the work that everybody does, and Safdar, for your continual commitment towards supporting the donation process, but more importantly towards your patients and just being a fantastic physician. Thank you so much.
Thank you, Hedi. Thank you, Harry. And thank you to the entire audience.
Thank you.